Good evening, my dear colleagues and friends. Today as you may remember, last week we tried to cover the different drugs approved in the treatment of HER2-positive metastatic breast cancer, and the very final take-home message was that the performance of Trastuzumab-deruxtecan is unprecedented, and it is actually the best drug we have at the present time. Today, we'll try to throw some light on HER2-low, and I wish to review with you what we have said the last time, that the normal cells, any cell, it doesn't have zero expression of HER2 receptors. Actually, they have a pretty high number, in the range of 20,000 receptors per cell, per normal cell. What happens in breast cancer, actually, the HER2-positive disease, is that we have amplification of the gene copy number. We have more gene copies within the cells, and these genes will induce transcription of a very large number of HER2 receptors that would reach something like 2 million cells per receptor. So, of course, the expression is not normal and overexpression. It's a continuum, and we have seen that last time. We have either HER2-0, which is on the low side of its expression, and HER2+3, which is in the high side of expression. But in the very middle, we have some sort of HER2 expression, but it is not high, so we call it HER2-low expression, which essentially includes all cases of score 1 by immunohistochemistry, and those with score 2 with H negative. So they are called HER2-low. In some tumors, and we know that this is a rather frequent event, we have HER2 heterogeneity, which means that in one tumor you may have an area of HER2+3 and other areas of HER2+1 or 2, or even HER2-0. This is called HER2 heterogeneity. It is present in something like up to 40% in some studies. And of course, they do not respond as good to anti-HER2 therapy, because the target is not present equally in all the cancer cells. But what I'm trying to discuss with you today is that we have some HER2 expression in the HER2-low. They have messenger RNA not as high as HER2-positive +3. And they have some receptors more than the normal, but it is not an overexpression. The item HER2-low, actually, the interest was there, try to target this disease by trastuzumab. We have one of the studies, adjuvant. It was a big study, actually, including more than 300 patients, and they put the definition of HER2-low, as I told you, +1 or +2 with H negative, and I randomized the patients to receive chemo or chemo plus trastuzumab, and the outcome was zero, practically zero, no benefit at all. In another smaller subgroup analysis in one of the studies with the T-DM1, you can see in this study we have something like 20%. They have HER2-low. And as you can see, the clinical benefit of TXD in these patients is practically negligible. So to do a better job on TDM1, we have seen that last presentation. TDM1 is a very good molecular antibody, trastuzumab, that holds in conjugation DM1. The antibody drug ratio, as we mentioned last time, is 3.5. DM1 is a very potent chemotherapeutic drug that is able actually to to kill the HER2 positive, but it doesn't have the feature of being membrane permeable. That's to say, it is unable to get outside the treated cell. So it doesn't actually reach the nearby HER2-low tumors or HER2 heterogeneous tumors. Trastuzumab-deruxtecan is again trastuzumab, but it has different chemical engineering. They have another more potent, actually, and chemotherapeutic agent, which is DXD. It's a derivative of irinotecan, but it's much more potent. And this DXD actually has the feature of being membrane permeable, which means it can really get outside the cell and to reach the neighboring cells, what we call bystander effect. To try to see this in this cartoon, we know that antibody drug conjugate will reach the receptor on the surface, the HER2 receptor, and then it will be internalized, as we mentioned last time, and then the antibody drug conjugate will be degraded inside the cell, that it will release the chemotherapeutic agent, and then the chemotherapeutic agent in the cell will kill this cell. When the cell is killed, if the drug is not membrane permeable, then the neighboring cell will not be affected. But if the drug is membrane permeable, like the DXD, actually, it will reach the neighboring cell, even if it is HER2 negative, and it will induce cell kill to this HER2 negative cells, actually, or HER2 low. So the whole era of interest in HER2 low, actually, it stemmed from that we have the drug with this capacity to kill the HER2 negative and HER2 low nearby cells, which is the Trastuzumab-deruxtecan. And this is one of the early manuscripts on HER2 low. The interest started in something like the last 5 years, probably. And we knew from this review, for instance, that HER2 low is responsible, that's in orange, responsible for something like 45 to 55% of all breast cancers, while HER2 positive, as we know, it is from 15 to 20%, while HER2 zero, it is from 30 to 40%. So in essence, HER2 low actually is the most frequent phenotype in breast cancer. And the definition, as we mentioned, immunohistochemistry +1 or 2 with the FISH negative. And we have seen that the classical drugs, including TDM1, they do not have a benefit in this kind of HER2 tumors. What we need to know about HER2 low tumors is that it is well established. It has a dynamic expression. We don't really understand why this discordance between the primary and metastatic tumors, but 40% we have discordance between HER2 low in the primary and in the metastatic phase. Usually HER2 low expression is more enriched in the metastatic phase, and that's why if ever you need to check on the HER2 low status, you need to do repeated biopsies. Actually, not only one biopsy, but with in this trial from Mass General Cancer Center, they had a biopsy in triple negative breast cancer with each and every progression during the metastatic phase, and they reported that with each successive biopsy of HER2 zero disease, a new HER2 low result was present in almost 1 out of 3. So that's the importance of doing repeated biopsies. In San Antonio, 2022, this topic was very hot actually? Is it HER2-low? Is it a different biologically or clinically different entity? We have many institutions. They reported their data to suggest that HER2-low is a separate entity. Mainly, it has a little bit of a better prognosis, but we have other more data set to tell us that it is not a separate entity. It is as HER2 zero actually. And importantly, in many of these studies, they used gene expression profile, and in red on your left-hand side, many groups, they used the gene expression profile, and they reported that that HER2-low is molecularly distinct from HER2 zero, while on the right side, and doing similar exercise by gene expression profile, other institutions, they reported that there was no real differences in the genomics of patients with HER2 zero or HER2-low. I'll show you an example for that. That's a very important study from the Spanish and Italian group, conjoint work. They brought more than 3,500 cases of HER2 negative, and the majority, of course, were hormone receptor positive. And they reported on the HER2-low. You can see that on your right-hand side, in triple-negative breast cancer, HER2-low represents around 1/3 of the population. The majority of population, they are actually HER2 zero, while on the other hand, patients with hormone receptor positive, around 2/3 were HER2 low, while only 1/3 was HER2 zero. So now we know, we're sure about that the prevalence of HER2-low is more seen in hormone receptor positive rather than triple negative, but it is present in around 1/3 of triple negative. They are HER2-low. They have done in the same study gene expression profile, and in hormone receptor positive, there was no difference almost between HER2 zero and HER2-low, and same applies for triple negative breast cancer. So these authors and many others, they could show that there was no real difference by gene expression profile between HER2 zero and HER2-low, whether it is hormone receptor positive or triple negative. And actually, they have shown in this study that there was no difference in overall survival, pointing to the information that the disease is not different biologically speaking. It's not more aggressive or less aggressive. And in US, again in San Antonio 2022, an intergroup in US, they brought the database from the National Cancer Database. They brought more than 1,100,000 patients with HER2 negative breast cancer, and they show in your left side the triple negative and your right hand side the hormone receptor positive, and there was no real difference between HER2-low, that's in light green here, or on light orange, or in light red, between HER2-low and HER2 zero, whether in triple negative or in hormone receptor positive. So taking together, I don't believe personally that it is different biologically or it is different clinically, but it is important because we have Trastuzumab-deruxtecan, and because of the peculiarities of the mechanism of action of Trastuzumab-deruxtecan. This study was designed actually to use Trastuzumab-deruxtecan in patients who were HER2-low, previously treated, and by many lines, including chemotherapy, at least one line of chemotherapy and one line of or more of endocrine therapy, and they were randomized to receive Trastuzumab-deruxtecan versus any chemotherapy you wish to give, either capecitabine, eribulin, gemcitabine, taxanes. And the majority, as expected, they were hormone receptor positive. You know, this is more prevalent in hormone receptor positive. And the majority of these patients with hormone receptor positive, they received a CDK4/6 inhibitor before progression. That is in the primary endpoint, the progression-free survival, and the secondary endpoint, overall survival in patients with hormone receptor positive. As I mentioned, the majority, you can see that the Kaplan-Meier curves are so impressively separated in favor of Trastuzumab-deruxtecan versus the chemotherapy. The chemotherapy actually is what we do in the treatment of this population after failure of endocrine treatment. In the smaller subgroup in exploratory analysis of hormone receptor negative, which we used to call triple negative, again, a similar benefit in favor of Trastuzumab-deruxtecan versus chemotherapy. So if you wish to have a look on the subgroup analysis, the prior failure of CDK4/6 inhibitor did not account for the activity, and whether it is immunohistochemistry +1 or +2. I was under the impression that we'll see more benefit in patients with +2, which didn't happen. That's why +1 and +2 are equally to benefit from Trastuzumab-deruxtecan. Prior lines of chemotherapy, whether we have visceral disease at baseline or not. Of course, patients with no visceral disease, as with other drugs, they have much longer progression-free survival. In this situation, it is 17 months, and in visceral disease, it was something like 10 months, which is, again, very impressive. Overall response rate, one of the highest you can see, especially in heavily pretreated patients. The overall response rate exceeded 50% with occasional complete remission in this population. So the problem in HER2-low diagnosis is not that easy. I will share with you an important publication which they brought very expert pathologists, 18 expert breast cancer pathologists, and they reviewed 170 breast cancer biopsies, and the concordance between these expert pathologists between HER2-0 and HER2-1. The problem mainly is between HER2-0 and HER2-1. HER2 +2 is easier actually to differentiate. So it's still not fully resolved, and I just want to tell you that before the presence of Trastuzumab-deruxtecan, we were not really interested to know whether it is 0 or +1, because we didn't have the treatment for these patients. So the guidelines was made for HER2 studies, essay is to differentiate between HER2 positive and HER2 negative. Now, with HER2-low, probably the guidelines will change, the pathology guidelines will change. The second important point is, as I told you before, it is a dynamic expression. It changes all the time, and that's why we need the biopsies. So the take-home message for HER2-low, that's my last slide for HER2-low. It represents a large population of all breast cancer patients, approximately 50 to 55%, predominantly HER2-low. It is predominantly seen in hormone receptor positive. More than 85% of HER2-low, they are hormone receptor positive, actually. But the incidence of in hormone receptor positive, it is around 50 to 60%. It is much less in hormone receptor negative. It is dynamic, as I mentioned before. It is changing over time, more enriched in the metastatic phase. Whether it is prognostically and biologically distinct, it is not totally settled, but my own opinion, it is not a biologically distinct subtype. And but we care because it's a targetable subgroup of patients. Now we have target for these HER2-low patients. The term HER2 ultra-low has been introduced more recently. We know on your left-hand side that is the HER2 testing. That's the CAP ASCO guidelines. If it is +3, it is HER2 positive. If it is +2 with each positive, then again it is HER2 positive. But if it is +2, each negative, or +1, it is HER2-low. If it is zero expression of the HER2 assay, or the cells are faint staining in less than 10%, it is HER2 negative. Now we started to dissect the HER2 negative to HER2 with no HER2 staining at all, which we call pure HER2 zero, or HER2 ultra-low, which is HER2 negative, but with less than 10% of the cancer cells, they have some brown staining. And at the present time, we have the Destiny 06, which is focusing only on patients who progressed after CDK4/6 inhibitors, including HER2-low and HER2 ultra-low. And of course, in this study, the pathology is done centrally. By now, we need to go to the more important thing in the clinic, which is HER2 positive early breast cancer. Of course, trastuzumab is the backbone. It was the backbone and still the backbone, and I think it will remain as a backbone for a long time. We have 4 pivotal trials that were published during the last 2 decades, several times. The NSBP study, it was very simple study, AC times 4, followed by paclitaxel times 12 weeks, or the same treatment with trastuzumab giving during paclitaxel for 12 weeks, and then it is continued for a total of 1 year. Remember, we do not combine trastuzumab with anthracyclines. Please remember this. The second study, it was mainly in Europe, giving trastuzumab sequentially. That's to say, you finish the chemo, any chemo you'll give, and you finish your radio, and then you give trastuzumab for 1 year, or you don't give trastuzumab, and we have a third arm to give trastuzumab for 2 years. The NCCTG, which is a US intergroup, they have done 3 arms, 2 arms like the NSBP, AC plus weekly paclitaxel, or plus weekly paclitaxel and trastuzumab, and a third arm actually, which was to give the trastuzumab sequential. So here we have the comparison between sequential versus a concomitant trastuzumab with paclitaxel. And the 4th pivotal trial, the BCRG study, which had AC plus followed by docetaxel times 4 with orodat trastuzumab, and a third arm, which was at that time a very dangerous study, because it has a third arm to give docetaxel plus carboplatin, that's to say no anthracyclines at all, concomitant with the trastuzumab, and then to continue always for 1 year, trastuzumab for 1 year. That's the HERA study, one of the biggest studies actually. They had the 1 arm trastuzumab versus observation, and the second trastuzumab for 1 year or trastuzumab for 2 years. Let's have a look on the main study, which is trastuzumab for 1 year versus no trastuzumab. You can see the improvement in at only two years follow-up. The outcome very impressive in favor of trastuzumab, sequential trastuzumab. The absolute gain in disease-free survival at 2 years was more than 8%. This was a very good news. The intergroup study, which had 3 arms, 2 of them utilizing trastuzumab, with paclitaxel, sequential, or concomitant with paclitaxel. So it was the only study that compared sequential use, that's to say paclitaxel with trastuzumab, or you give paclitaxel first and then you give trastuzumab. So here the question, sequential versus concomitant, and we have seen that the upper curve is the concomitant. It was better than the sequential. The absolute gain was more than 4% at 5 years. So important to remember is the cardiac toxicity. This publication we have made several years ago, Hatem and Dr. Bernard De-escalation from Gustave Roussy, and we have put the cardiac toxicity in the different pivotal trials. The upper one is the HERA, which is sequential, and in the HERA they have more fit patients. They mandated to have baseline left ventricular ejection fraction more than 55. You can see that if you give trastuzumab, the cardiac toxicity, severe heart failure was pretty low. While in the other studies that given concomitant concomitant trastuzumab with chemotherapy, you can see that with chemotherapy alone, the congestive heart failure rate is low, although it has anthracycline. But when you added trastuzumab, the congestive heart failure was much higher actually. And in the intergroup study, which had the arm of sequential trastuzumab with paclitaxel, the severe heart failure was less. So we need to understand sequential chemo, it appears a little bit less effective, but it is certainly less cardiotoxic. So if your patient is elderly, we have borderline normal left ventricular ejection fraction, you may decide in the MDT to give the adjuvant trastuzumab sequentially rather than concomitantly. For the concomitant use of trastuzumab, which we prefer, of course, we have two studies, the NSBP and the intergroup. The intergroup, they have the third arm of sequential, which was removed, and the two studies actually they had a design to allow for their combined analysis because they have identical arms in the two studies, and this is the largest data set for the concomitant use of trastuzumab. You can see that the improvement in disease-free survival, that's in overall survival, at 10 years, we have absolute gain around 9% improvement in overall survival, very impressive improvement in overall survival, and again, very impressive improvement in disease-free survival, around 11% improvement in disease-free survival. But if you look into this and you want to be a little bit critique, you can say, well, in 62% of the population who did not receive trastuzumab and they had HER2-positive disease with chemotherapy alone, they never relapsed at 10 years, which could open the question, can we do some treatment de-escalation in this population? Let's see the studies that try to address this point. They have a lot of caveats, a lot of problems in the design, but I will review with you because they are very relevant to our talk today. We have 3 studies in light blue that compared 6 months versus 12 months. 12 months is of course the standard, and you have 2 studies that you use this 1 year, 12 months versus 9 weeks, a very short time of trastuzumab treatment. Anyway, the study design was non-inferiority, which means that, of course, we are really sure that 1 year should not be less than shorter treatment. So we mean that the shorter treatment is not non-inferior, which means is not too much below the outcome with 1 year. The term not too much below, not unacceptably below, is called non-inferiority margin. And I think, Luay, probably in your statistical reviewing with our junior colleagues, you will certainly have some time to tell them that the importance of having the non-inferiority design. But anyway, باختصار هي انه الشورت ديوريشن مش اوحش مش اقل بشكل ملحوظ من ال 1 year duration. Okay. So during the ESMO 3 years ago, we have a beautiful individual patient meta-analysis that brought the 5 studies. They brought the individual data of the 5 studies in the randomized in the 2 arms, and they brought this information. If you wish to compare 12 months versus 9 weeks, 9 weeks was certainly not non-inferior. That's to say, it tends to be inferior. So don't use this 9 weeks. For the 6 month, versus 1 year, the 6 month was significantly non-inferior, was significantly not worse. And the absolute difference at 5 years was 0.7%, 0.7%, which is very negligible. And because of this, we were really encouraged to put that in our guidelines. But my own view, actually, all of these studies, actually, they utilized shorter duration. They did not do this in low-risk population. They included all patients from stage 1 to stage 3, not positive, not negative, ER negative, and ER positive. So actually, we cannot try to utilize short duration in high risk population where treatment escalation actually is needed. So who can we really give the short duration? We have put that in our national guidelines. When I was responsible for that, Dr. Luay was a partner in this guidelines. We mentioned that tumor less than 3 centimeters, node negative disease. If it is node positive, then it is 1 lymph node with micrometastasis. And we have seen that the escalation of chemotherapy, not trastuzumab, was done in this population in the APT study. APT stands for adjuvant paclitaxel trastuzumab, and it was a single arm, actually, not randomized, and they included patients with low risk population, not negative, less than 3 centimeters. And you can see that at 7 years, the relapse-free survival was 97%, which is very, very impressive. So because in Egypt, we care to do some cost saving to utilize less trastuzumab duration. So we opted to use actually to de-escalate the trastuzumab to 6 months, because we have the meta-analysis that showed us that 6 months is not non-inferior. And we give concomitant with chemotherapy, of course, not sequential. And importantly, in the studies that compared 6 months versus 1 year, the cardiotoxicity for 6 months was always significantly less than the cardiotoxicity of 1 year. So taking together, actually, we decided in our guidelines to keep the standard chemo for 18 weeks, while de-escalating trastuzumab for 6 months. That is in node negative. Please remember this. And in small t, this data from the British Columbia database, which is one of the best databases in the world, in cancer treatment. They reported almost 10 years ago that the presence of node-positive disease versus node-negative disease, it makes a lot of difference when it comes to prognosis of 1 year of trastuzumab. So node-negative, the prognosis is perfect with 1 year of trastuzumab, while node-positive, the prognosis, of course, it improved versus chemotherapy alone, but still at 5 years, you lose 18% of this of these patients. But if you wish to see what will happen in subsequent years, I will show you the BCRG study. The BCRG study, they reported over several times. That is the outcome in the different arms. Remember, the yellow Kaplan-Meier is chemotherapy alone. The blue chemotherapy anthracycline based with the trastuzumab, and the red is non-anthracycline with trastuzumab. That what happens at 5 years, but after 10 years, we lose much more number of patients. So this population, they go and relapse even after trastuzumab treatment. Still, of course, trastuzumab improved the disease-free survival, but the patients, they are relapsing all the time. And if you wish to focus on not positive, that is in over 10 years, you lose around 30%. With trastuzumab treatment for 1 year, you lose 30% of the population in not positive population. Here, of course, you have to decide. You need to escalate the treatment. While if the patients they have N2 or more, even you lose around 38% at 10 years. Again, of course, escalation is needed. To do treatment escalation after in non-positive disease, we have several ways to improve the treatment outcome. The first is the adjuvant approach, actually, which now we do not do much because we focus more in the neoadjuvant model, and we'll discuss both approaches actually. In the adjuvant setting, we have seen that the success of 1 year of trastuzumab. So when added to chemotherapy, whether sequential or concomitant. So the question is very valid. If 1 year of trastuzumab is very effective, then why not to give it for 2 years? And you may recall the HERA study, actually, they randomized the patients, one arm to receive no trastuzumab, second arm to receive 1 year of trastuzumab, and third arm to receive 2 years of trastuzumab. And here we are, that is the difference between 1 year and 2 years. If anything, there is no benefit at all from 2 years of trastuzumab, whether in hormone receptor positive or hormone receptor negative. And of course, it added a little bit to the cardiac toxicity, which is in blue. The 2 years cardiac toxicity, as you can see in your right-hand side, it was a little bit increased with the 2 years versus 1 year. The second point is to add one of the tyrosine kinase inhibitors in addition to trastuzumab. You know, trastuzumab, it will block the receptor from outside, while the tyrosine kinase inhibitors will block from inside, which we call total blockade of the receptor. You do that with either lapatinib or naratinib. And we have discussed the two drugs last time. Naratinib is expected to be a little bit more effective compared to lapatinib. But let's see the outcome with the naratinib. This is the XNAT study, that is patients who received 1 year of trastuzumab and they are disease-free after the 1 year of trastuzumab, were randomized to receive another year of naratinib versus placebo. That's to say, that is extended adjuvant, 2 years of anti-HER2 treatment. 1 year already trastuzumab, and the second year is naratinib versus 1 year of trastuzumab and placebo. They included high-risk population. majority were not positive or patients with residual disease after neoadjuvant treatment. And that's the outcome of, at 2 years. Actually, in the intent to treat, we were amazed to see this kind of improved disease-free survival in favor of naratinib. And in the subgroup analysis, the favor was the favorable effect was essentially seen in hormone receptor positive, and practically there was no benefit at all in hormone receptor negative. And at the subsequent follow-up at 5 years, the same what we have seen in 2 years analysis, the gain was seen in hormone receptor positive, very significant hazard ratio 0.60, absolute gain at 5 years of around 4.5%. There was no gain at all in hormone receptor negative, and that's why the approval in Europe was to use naratinib in patients who are disease-free after 1 year of trastuzumab, and they have high risk to relapse, either not positive or residual disease after neoadjuvant treatment. And in hormone receptor positive, in the FDA, they gave the approval for hormone receptor positive and hormone receptor negative, and I don't see, of course, why to use it in hormone receptor negative. But anyway, the other approach in the adjuvant setting is to keep the duration of adjuvant treatment at 1 year, and you add one extra anti-HER2 drug with trastuzumab. Here we have the ALTO study, and the ALTO study, they have 4 arms. We will focus on 2 arms, the arm of trastuzumab alone, because that's the standard, and the other arm was trastuzumab for 1 year, combined with lapatinib for 1 year. Actually, the combination arm, they suffered from more toxicity, more drug discontinuation because of toxicity. But let's have a look on the outcome. The green is the trastuzumab lapatinib, and the blue is the trastuzumab alone. There was a trend actually in favor of the combination of lapatinib trastuzumab, but it did not reach the predefined statistical significance. So the drug was not approved for to be combined. Lapatinib was not approved to be combined with trastuzumab in this indication. The other study is more famous study, the Affinity trial. They have similar design, but only 2 arms, one chemo plus trastuzumab, and the second is chemo plus trastuzumab and pertuzumab, or all the treatment for 1 year. And in the not positive, we have seen the outcome in favor of 1 year of pertuzumab with trastuzumab compared to trastuzumab alone. The absolute gain was around 4.5% at 6 years. But look at not zero, actually, there was 0 benefit. So once again, actually not 0, you don't need to give extra treatment. On the contrary, you may need to de-escalate the treatment in not 0. Importantly, after longer follow-up in the Affinity trial, we have seen that the outcome benefit of 1 year of pertuzumab was beneficial for patients with not positive. The other way of escalation the treatment is to utilize the neoadjuvant approach. The neoadjuvant approach actually the neoadjuvant therapy was basically introduced into the breast cancer therapy as a way to improve resectability and to reduce the risk, the rate of mastectomy and axillary lymph node dissection. So it was meant to shrink the disease, to do less aggressive surgery. Later on, we knew that neoadjuvant therapy can serve for identification of biologically high-risk population, which are the no PCR patients. And we have seen many studies, including this large meta-analysis of more than 36 studies with more than 5,700 patients. patients, all patients received neoadjuvant chemotherapy plus trastuzumab. You can see that the PCR rate was around 30 to 40% in this population. But those who achieved PCR in your left-hand side with hormone receptor negative, your right-hand side hormone receptor positive, PCR was much better prognosis than non-PCR. The effect, of course, was more seen on your left-hand side. The separation of the Kaplan markers is more seen, but again, it was significantly separated in hormone receptor positive. What does it mean? It means that if you wish to have your patient surviving for a long time and you give neoadjuvant treatment, then try to give the neoadjuvant treatment that is able to increase the PCR rate. So now we have studies to see which regimen will increase the PCR rate, because if you increase the PCR rate, then your patients will always be on the upper curve. But if your patients fail to achieve a PCR, and this, of course, it happens, then unfortunately, your patients will be on the lower curve. Then you have to do something for these patients. Try to treat them after the neoadjuvant setting with another treatment to improve their poor prognosis. So let's see how we can have a PCR rate, the higher possible PCR rate. This Neosphere study was the first introduction of pertuzumab plus trastuzumab in this arm, pertuzumab trastuzumab plus docetaxel versus docetaxel and Herceptin alone. And there was a significant increase in the PCR rate, and because of this, actually, pertuzumab was approved in the neoadjuvant setting. But we have a certain caveat in this study, which is they gave only 4 cycles of docetaxel plus anti-HER2 therapy, and nobody actually will agree to give only 4 cycles of one drug chemotherapy, which is docetaxel. So the caveat, the concept was approved that the combination of trastuzumab plus pertuzumab can improve the PCR rate compared to trastuzumab alone, always with docetaxel. But you need to have studies with more conventional chemotherapy, with more classical chemotherapy. And we have several studies, among them the Trifenia study. That's a German study that utilized 3 regimens on your right-hand side, a non-anthracycline regimen here, and pertuzumab, trastuzumab, always in the 3 arms. And in your left-hand side, that is FEC followed by Taxotere and pertuzumab, trastuzumab, always. And in the other one, what FEC with trastuzumab, pertuzumab, and docetaxel. Here you give trastuzumab with FEC, which is not advisable at all, but that was the design anyway. The PCR rate, whether you give no anthracycline here or you give any form of anthracycline, was the same. So that was the first study in the neoadjuvant setting to suggest that you can go without anthracyclines, actually, and you achieve PCR rate of around 50%. Later, we have the Christine study, which compared TDM1, which we know it was approved in the metastatic setting, with pertuzumab versus non-anthracycline regimen, always carbo, docetaxel, trastuzumab, and pertuzumab for 6 cycles. And the outcome actually was in favor of the chemo arm with trastuzumab, pertuzumab versus the TDM1 plus pertuzumab. So you need chemo. Even if you have very good target therapies in HER2 positive, you need chemo, at least with the TDM1. And whether in ER negative or in ER positive. Always you'll see that ER negative, HER2 positive, they respond to anything you give much higher than ER positive, actually. But whether ER negative or ER positive, you need chemotherapy with the anti-HER2 therapy. Then we had a third study, which was actually the main study that we follow its results at the present time, which is the TRAIN study. It is by the Dutch group, the Netherlands group. They gave around 6 months of chemotherapy, either paclitaxel, carboplatin, and pertuzumab, trastuzumab, for 8 to 9 cycles, or you give the first 3 cycles with the anthracycline-based regimen, and then you give subsequently the subsequent 6 cycles with paclitaxel and carboplatin. The outcome in PCR, which was the primary endpoint, was the PCR in around 65% plus. Remember, if you give only 6 cycles in all the studies, in the Traphenia or the Christine study with the same regimen, the PCR rate is in the range of 55%. So it means that longer treatment is in some patients at least is may be needed to increase the PCR rate, actually, especially in locally advanced patients. And according to the hormone receptor positive or hormone receptor negative, in your left-hand side, in hormone receptor negative, with this long-term treatment, the PCR rate is extremely high, more than 85%. This is almost like the treatment of lymphoma, for instance, better than lymphoma. And even in hormone receptor negative, certainly it is much less, 30% difference in PCR rate, but the PCR rate is in the range of 50%. So it was important to remember in the MDT that in patients low responders, you may need to prolong the chemo a little bit, actually. Whether you need anthracyclines, the answer in PCR, we don't need anthracyclines compared to non-anthracycline. And in event-free survival, the event-free survival was exactly the same. So toxicity was as expected. Cardiac toxicity was significantly seen in the anthracycline arm, and neutropenic fever as well was more seen in the anthracycline arm. So what was not really explained for me, but in the publication, the authors reported that there was no increasing neuropathy in patients who received 9 cycles of paclitaxel plus carboplatin versus who received 6 cycles of anthracyclines. Anyway, this work we have done with Luay and Shaima, and we published several years ago, how we balance the efficacy and toxicity with the anti-HER2 therapy. And our view was that an anthracycline-free regimen is the way it should go in most patients. This does not mean that if you use anthracyclines, this is wrong, but you have to have a good residue of anthracycline, actually, which we can discuss later. We'll go back to the outcome. The outcome, if your patient failed to achieve PCR, that this means she will be on the lower curve, and the prognosis here is extremely poor with the classical neoadjuvant treatment and 1 year of trastuzumab. So here we need the new approach in breast cancer oncology, which is response adapted studies, which means that you treat your patients. If the response is PCR, then you're in good hands. Your patient is fine. If it is with no PCR, then take these patients. We know they have poor prognosis, and try to use another treatment. And one of the earliest response adapted studies actually was the Catherine trial, which brought patients with residual disease, HER2 positive, after chemo plus Herceptin plus or minus pertuzumab, and patients were randomized to receive the standard treatment, which was to complete 1 year of trastuzumab or to shift to TDM1. And we have seen in this study that was breaking news 6 years ago that we could improve the event-free survival in this population dramatically at 3 years. Only at 3 years, the improvement was 11% absolute gain in the invasive disease-free survival. Importantly, in all subgroups, meaning all subgroups, in ER negative, ER positive, in not negative and not positive. Even in very large tumor like T3 lesions, the absolute gain was 17%. For prior Herceptin or prior Herceptin plus pertuzumab, again, the improvement was very, very impressive. Even for those patients with very small residual disease, those with the residual T1B or T1C, the outcome was improvement with around 5% improvement. During the last San Antonio, again, we could see the updates of this study, and in this particular trial, there was improvement in overall survival. The absolute gain in overall survival was more than 8%, more than 4.5% in favor of TDM1. And that's one of the important studies that could show that we can really improve over and over the overall survival in this population. But still, we have a few problems with the Catrine. The challenge is that in patients with T3 or ER negative or lymph node positive, still at 3 years, we lost more than 15% of the patients. Again, the CNS relapse, although the overall distant recurrences were significantly less in the TDM1 arm, but 50%, more than 50% of the relapses in the TDM1 were in the CNS. Remember, the HER2 story with brain metastasis, of course. So how can we improve over this? We have at the present time 2 ongoing trials. We have the CompassHER, which added after patients with residual disease, with high-risk residual disease, any ER negative and ER positive, if not positive. So now we are getting more high-risk population with residual disease to receive the TDM1 as standard treatment, or TDM1 plus tucatinib times 14 cycles. This study is ongoing. During the last San Antonio, actually, we have seen the first the results of the first combination of tucatinib plus TDM1 versus TDM1 in a randomized study, but in the metastatic phase. And we have seen that the combination tucatinib plus TDM1 was better than TDM1, significantly better, although it was not very, impressive separation of the Kaplan-Meier curves. Whether we will see a better outcome with this combination in the post-neoadjuvant setting, it remains to be seen. And of course, the Trastuzumab-deruxtecan, the big guy in treatment of HER2 positive. We have the Destiny-05. This is a very important trial led by the German group, actually. You will bring patients with residual disease to receive TDM1 as standard treatment versus the investigation arm of Trastuzumab-deruxtecan. And I'm sure that this will end up by TDM1 Trastuzumab-deruxtecan as a winner, but still we need to see how the patients will tolerate this treatment. And by this slide, I came to the end of my presentation and waiting for your discussion. And thank you so much.